Thank you for having me here today. This effort is absolutely vital to the public and to the U.S. healthcare system. The recent evidence says that despite a lot of discussion, there's virtually no evidence that patient harms have been reduced over the last decade. And perhaps the one notable exception is some of the work to reduce bloodstream infections in ICU patients, one of the interventions that is in the best practices. And if I think about what we've done over the last decade, I'm reminded of a quote by Rusty Shumpter. Rusty was an astronaut in the pre-lunar Apollo mission and was asked what the Middle East looks like from outer space. Really telling time now what's going on in the world. And his words are so powerful. He said, what I noticed is that there's no lines in outer space. We invent them. They're figments of our imagination. And yet on Earth, we kill people over those imaginary lines. And if I think about efforts in quality over the last decade, I see a whole lot of lines. Lines at the federal level, at the state level, and within healthcare organizations, and within the research community. A very bright line between basic and clinical research, and then less emphasis on health delivery research. I see efforts that have been much more independent than interdependent, more competitive than cooperative, and frankly more focused on what we do than the results we achieve. And why I'm delighted to be part of this effort is that it's erasing those lines. And those lines are desperately needed to be erased because no one group is going to do this alone, and science has to guide the way. I'd like to share with you how we tackled one of those problems. It's an example of what you might expect out of this type of work. We sought to address that problem of bloodstream infections. I wish I can say we tackled it for noble reasons, but we really didn't. We addressed it because a little girl died at my hospital from one of those infections, and at the time our rates were exceedingly high. Now, I was one of those doctors unknowingly harming patients from those infections. I'm an intensive care physician. I certainly didn't want to be hurting them, but I was. And in part was because the science wasn't there, in part because we didn't measure these, and in part because we had the mental model that these infections were inevitable rather than preventable. So we brought to bear a checklist, we brought to bear good measurement, we brought to bear a culture that supports collaboration and teamwork, and we virtually eliminated these infections from our ICUs. Unheard of performance at the time. We then, with the grant from AHRQ, packaged the program and put it in the whole state of Michigan. And within 3 months, cut infections in over 100 ICUs in half. Within 6 months, they all had a median of 0. The overall mean reduction was 70%. And we recently published some really remarkable examples of what's possible. Those results have stayed at 0 for now 4 years. The mortality of any Medicare patient admitted to an ICU in Michigan, independent of whether they did this program, was reduced by 10% more than the similar patients in the 11 surrounding states. In other words, as a policy level intervention, this program moved a whole state's mortality. We will be publishing later this summer that the average hospital saved somewhere between $1 and $2 million from this effort, and that the results were able to spread to other states. So Rhode Island replicated the results, Hawaii replicated the results, and now that program has been put in state by state in partnership with the American Hospital Association and our research group and the Michigan Hospital Association in 48 states. The CDC recently reported that these ICU infections, which, by the way, to frame it for you, kill about as many people each year in this country as breast cancer. So we're not talking about some trivial problem. We're talking a public health problem of the magnitude of breast cancer, are down 60% across the country. Now, there's a whole lot of things that contributed to that. We erased lines, there's economic incentives, there's public reporting, but fundamentally, what we learned, what drove it, was 3 things. we kept score with measures clinicians believed were valid, right? And that's really important because you can measure things, but if the docs don't believe that it's useful, it's not going to, no one's going to use the data. Second, we were guided by science every step of the way. Both clinical science of what therapies work, but then, as you heard, implementation science. Because when early on, I certainly didn't want to not be using best practices, but we hadn't set up systems to make it easy for us. So we needed to understand the systems integration and the human factors engineering of why, and make it easy for our clinicians to comply with best practices. And we needed to tease out what are the cultural barriers and how do we improve culture. And lastly, we committed to collaborate. There was no one group that was going to do this alone. It required a concerted effort to join together. I think when I look around what we've done for quality, and I say this as a practicing physician, I think too often I felt like quality was something that was done to me rather than something I do. And Teddy Roosevelt has this great quote in 1908 when he was reflecting on some rather unscrupulous business practices. I think you could equate it to our healthcare system. Now, he said, man can never escape from being governed. If from lawlessness or fickleness, folly or self-indulgence, he refuses to govern himself, in the end, he will be governed. And I think that external approach has been the way we approached improving quality or safety, in part because my tribe, clinicians, providers, hadn't stepped up to the plate. But Roosevelt went on to say in his quotes, but it's important to recognize that law and the importance of law can never substitute for the character of the citizen himself. Right? And I think that if we're going to make progress on healthcare quality, it will have to be the clinical groups who see this as a social problem, who own the problem, who develop the science, who develop the measures, because quite frankly, we've grossly underinvested in this science. The federal government spends 2 pennies on health delivery research for every dollar it spends finding new genes and new drugs. So we have a great pipeline, and we need a pipeline. That pipeline saves lives of basic discoveries, of clinical discoveries, but then there's a huge gap between how do we make sure that those are used. And that implementation science has to be guided by science. It has to be with measures that clinicians believe, and this best practices effort is going to fill that void. It'll fill the void for making sure we train clinicians so those clinicians who are practicing now will understand this science every bit as they understand the double helix and genetics. It will help make sure that we develop measures that clinicians believe that are useful for improving, and it'll help us make sure that science guides us every step of the way, just like it has to help expand our life expectancy and all the other investments that the public has made to advance science. So I think this new opportunity is truly novel and breathtaking, and it puts the focus of leading these efforts where it should be, with clinicians and particularly with the academic medical centers who are bringing science to bear to this field that is in so desperate need. Thank you. I'm happy to take questions now. If
Actually, I see all of